Yeah, I think it's 12 o'clock, so we should start. Good afternoon, everybody. In absence of Dr. Daniel Atherton, who has to be at the court, it is my pleasure to introduce Dr. Stephen Rothenberg. Dr. Rothenberg is an assistant professor of radiology and an associate scientist at the Center for Clinical and Translational Science. He's the director of the Innovation and Imaging Informatics Lab, 3 Eyes, and the Imaging Informatics Fellowship Program at UAB. Dr. Rothenberg received his bachelor's degree in physics from the University of Maryland, College Park, and matriculated into medical school at George Washington University through the Early Assurance Program. He completed his residency at Diagnostic Radiology and fellowship training in imaging informatics at the University of Maryland Medical Center. The interesting part is, after his second year of radiology training, he pursued an industry sabbatical and founded Envoy AI. It's formerly called McCoy Medical Technologies. And this was the world's first radiology AI marketplace, which was fully acquired by TerraRecon. After the acquisition, he returned to complete residency and joined faculty at Maryland prior to his appointment at UAB Radiology. Dr. Rothenberg is a serial entrepreneur on a mission to unlock value by connecting key stakeholders to progress novel and impactful technologies to transform healthcare. His research interests include imaging informatics, opportunistic population health screening, and neuroscience. Dr. Rothenberg.
Hey, everyone. Hey. Oh. Well, thank you for that introduction. Hi, everyone. How's it going? All right. Well, thank you for inviting me to speak at your Grand Rounds day here. And this is my first Grand Rounds presentation, so thank you for inviting me. And I'm excited to talk to you about some of the work that we've done in radiology and some of my past experiences. And I hope that maybe you can learn a little bit from this, and it will be entertaining and interesting to everyone here who might have an interest or is excited about AI in healthcare. I do have a bit of a myopic view. Here are some of my disclosures. I do have a bit of a myopic view, so I am, a chest radiologist. So most of my domain expertise in AI is in image processing, specifically in radiology and in medical imaging. But I figured I'd start off this talk by just showing an image that is generated by ChatGPT's DALL-E. And I use this prompt here. And I think it's kind of funny that the picture looks really, really cool, but for some reason, everybody in this photo is facing a screen and they're not facing me, which is kind of a little bit weird, but it looks super official. I mean, I think actually this is what's happening on Zoom. So maybe AI is actually right here. I don't know, we'll see. So yeah, just a little bit about me. Thank you for that awesome introduction. I did a quick industry sabbatical. I raised some venture money, started this company called Envoy AI. Yeah, this clicker thing isn't working. All right, looks like I'll be using the mic or the, anyway. So sorry for the technical malfunction. Let's see if this is working now. So started out at University of Maryland, started a startup. We built infrastructure for AI, so we didn't actually do any of the model development, but we built all of the things that are necessary to actually get it into the healthcare system without, that's not specific to a given algorithm. That company was acquired by TerraRecon, and I returned back to University of Maryland and joined faculty at UAB. So since then, I've done 3 kind of prospective trials of different AI technologies, some that we've developed ourselves, some that we've implemented from vendors. I've participated in a couple of these FDA validation studies. I've implemented 6 different products here at UAB. And then we've developed one thing in my lab and actually recently got FDA clearance for that. So the purpose of this talk, I'm going to just I'm going to give a broad overview about AI, and then I'm going to talk about what I think are the key factors of success for AI in medicine. Now, granted, my view is coming from the radiologist perspective, and I'm not an expert in pathology. I don't have a strong understanding of the clinical applications or the applications or the pain points and problems in pathology as well as y'all do. But I do think that some of these things will overlap and could be useful. And I'm going to review a bunch of different solutions of AI in radiology. Radiology has had a lot of AI applications and a lot of interest, partly, I think, because the data for radiology is much more available than it is for pathology. So radiology data is all digital, everything's there. There's no physical infrastructure like we need in pathology in terms of storing the slides. Everything is saved digitally. So I think that just lends itself very, very well to developing AI, which is why it was one of the first areas I think there was a lot of interest and buzz. And then I'm just going to tell you a little bit about things that we've learned in radiology, and maybe these will be useful to those who are interested in the space or want to get involved. And so, what is AI? So AI is really programs with the ability to learn and reason like humans. And then machine learning is a subset of AI where algorithms have the ability to learn without being explicitly programmed, right? So in traditional software coding, let's say you wanted to develop a website, you would say, like, I want this background to look like this, and I want this color to look like that. With machine learning, you could basically take a bunch of different websites and then say, like, make me one that's similar to this. And then deep learning is a subset of machine learning that uses this neural network architecture. And then generative pre-trained transformer models, which was invented by Google and popularized by OpenAI, is a subset of deep learning. So when we're talking about AI in healthcare, we're really talking about narrow artificial intelligence. So we're talking about AI that's designed for a very specific task. And then the thing that you see in like the science fiction movies and what a lot of the Silicon Valley and big tech companies are working towards or want to do is to develop artificial general intelligence, which would mean that it would be a computer program that could behave like a human across all tasks. But that's really not feasible as well as even though we've seen like massive improvements and really exciting progress in the short period of time, I still think we're very far away from this. So just to give you a tangible example that you can kind of wrap your head around. So with a typical regression analysis, you might fit a line saying like, hey, let's separate these two different points, right? So imagine we have benign nodules that are green and malignant nodules which are red. And these are some imaging features that we might pick out on a CT scan. With a regression model, we would basically say like, hey, can we divide these two groups somehow? With machine learning, we can essentially say, hey, computer, figure out what you think the formula actually should be by having all this data in a certain way. Now, this is like a two-dimensional representation of an algorithm, but you can imagine how complicated this can get when you have 400 or 500 millions of different parameters that you're trying to use. And so just to give you a quick example, imagine we created this like kind of stereotype survey and we tried to guess who was male and female in a cohort of people who answered these questions. So when we asked 10,000 people, what's your favorite color? Would you prefer rather watching Dancing with the Stars or an NFL football game? What movie would you prefer watching at night? Star Wars with a notebook? What's your height and weight? Some variables. And then we tried to figure out some information. So descriptive statistics, you would think that more women might like pink, and so there could be an association. Now it's not a causation, right? Only third grade Steve would have thought that liking Dancing with the Stars made you a girl, but that doesn't really work that way. And a regression formula would basically say, hey, let's take a couple of these variables and let's try to create some analysis so that we can predict what the next thing is. But what about really, really complex combinations and patterns using these variables? Are there ways in which we could fit the data in a really, really clean way? And so imagine that we did this and we did our algorithm training on data that was all from the US. And then we decided to say, hey, let's see if this algorithm can predict gender using those variables with people from China. Now, people in China, football really isn't a popular sport in China. So now all of a sudden, that variable's out the door. And so that thing's not going to work. And then, people might be a little bit smaller or shorter, and they might have different body habitus, especially, compared to the Southeast. And so all of a sudden, the algorithm with predictive performance is obvious that it might not work as well in this population. And so we need to have the same sort of boundary conditions and understanding of an algorithm or a machine learning application when we start using healthcare data or complex variables that we just don't quite understand. Now, imagine we went and then asked 5,000 people imagine we trained this in high school kids in 2020. And then after Taylor's team wins the Super Bowl, we ask them again, right? All of a sudden you have all these girls who like football. And so now your algorithm is totally off. So this is the problem, and this is the overarching big issue with doing machine learning. And it's one of the hard things of doing this kind of research and doing this kind of development is that you build something, you have a hypothesis, you collect some data, and then when you go prospectively, everything falls apart. And so you have to be really, really careful about what's going on in your data. And this is just like a simple way to, I hope you can wrap your head around it. And so this is like kind of one of my favorite things. Like, it's all about the training data. What's in the training data, how it's labeled. And so if you go and you ask an AI algorithm to generate an image saying salmon swimming upriver, this is what you get. It's not wrong. I mean, that's salmon, right? This looks pretty good. That's a good color. But yeah, so anyway, so these are just to highlight some of the challenges with AI machine learning, why it's so important to have a rigorous way to validate these technologies as they're being implemented and used in healthcare. So I'm just going to give an overview here. Now I have way too many slides, so I might like speed up or slow down. So, but I do want to leave some time for us to have a conversation or just got. Please bear with me a little bit. Anyway, lots of money is being invested into healthcare AI. We are kind of in the peak hype cycle right now for generative AI. Like everybody is really, really excited about this technology, and everything always happens in waves, right? Everybody, since the release of ChatGPT, everybody is looking into different ways of applying this technology. And there are a lot of really, really exciting use cases, which I'll get into a little bit later. There are lots of different companies in healthcare that are attacking different sorts of things. And I kind of like this breakdown. There's like non-clinical applications or clinical applications. And each of those has different risk profiles. So radiology is really pretty advanced. And like I said, I think it's just because all the data was available. And so people started, making products because of there was the available data. But that doesn't mean that there aren't great applications that could be developed or that will permeate through healthcare. Now, the weird thing is that there's this regulated FDA space, but generative AI is so new that it's really like the wild, wild west. Everybody it's like there's companies doing things that you just are like it's kind of crazy, but and a lot of these are big tech companies. So anyway, so key factors for success for AI. So with AI, kind of like the broad example that I was talking about before, it's programs with the ability to learn and reason like humans. But really, we're thinking and we're looking and we're interested in augmented intelligence. And really what that is how do we use AI to improve our performance, right? How do we do a better job at our, at work? How do we improve care? And really the goals of augmented intelligence are to improve accuracy, precision, efficiency, decrease our error rate, and improve our clarity of communication. So what we've done in radiology when we're trying to determine, if we should buy a product or should we build something, kind of what we like to think about is what's the clinical value. So that's what I talked about before. We also like to think about it in terms of how simple is it to use, right? And so everybody likes ChatGPT. It's a really nice interface, right? It's super simple to do. It's like, you just type a text prompt and it returns back to you. It's very easy to use. And so we like to think, we like to make sure, and we put a lot of stress on how easy is it to use the technology. Because if it's not easy to use, then nobody will use it. Then you buy it and, it just sits on a shelf and we just wasted a bunch of our resources. And then the other thing we like to think about, or we hope, is, and we evaluate the technology to see like, well, is it actually going to improve the finances of the department or not? We kind of give it a little scorecard and, prioritize that way. This is, we have a lot of different products that we've kind of implemented. I'm just going to show a couple, and these are kind of the scorecards of, how we've graded them. So I'm just going to talk about some of the applications in radiology. So one of them is AI triage, so computer-aided detection. It's computer-aided detection and triage. What we're doing is essentially saying, hey, read this case first, right? And so we have an application that identifies critical pathology in our imaging exam, so pulmonary emboli, intracranial hemorrhage, those sorts of things. And then we have this little widget that kind of pops up, and we also have a badge that goes onto our radiology reading work list. And that essentially helps us know, okay, that study has a critical result. Let's read that one first so that we can, communicate those results to the ordering physician, and then they can get that patient escalated through the department. So these are kind of some of the examples intracranial of different sorts of triage applications in radiology. Now, we initially thought like, okay, we're going to be missing a bunch of PEs. There's like a high risk of fatality. If we have this AI triage tool, maybe it'll decrease our maybe it'll decrease the amount of PEs that we miss, and reduce our medical legal liability. We did a prospective study while we were implementing this. And so in phase one, what we did is we separated and had AI and humans not knowing that the other one was each looking at the study, right? So we had a barrier by them. So the AI was running in the background, but humans could not see any of the results. And then what we did was we had a sort of get to know you phase where all of the radiologists in our department were trained on how to use the tool. They got to play around with it. They got familiar with it, and they learned sort of the kinks. And then in phase two, we started data collection again and started to look at our performance. We ended up reviewing every single study, which was really painful, but we did it. And it really didn't improve our accuracy, our miss rate, or our turnaround time at all. So, we kind of had a little bit of a reality check here, in that like our detection with AI is we were still missing some stuff. We were still missing some PEs, but most of the things that we're missing are like, is that really a PE, or is that like a little, who knows what it actually is? Maybe it's like a little subsegmental thing. It's a kind of clinically uncertain thing. We didn't actually see any improvements in our turnaround time. One of the things that's like kind of glaring or like a little bit funny in the back is, interesting now, is like we were like, oh, we need to solve this problem to improve our turnaround time. Like we need to get studies and patients their results faster. But in radiology, we thought about this after we implemented it, and we're turning around our studies in 2 hours, 1 hour for stat exams, within 4 hours for non-stat exams. So is that prioritization of like 30 or that 30 minutes or hour that you could save, does that actually improve the outcome for the patient? And so that's where we're like, yeah, maybe not. So anyway, that was dedicated. That was an example of dedicated PE. So clinical value, we had few misses. Really no change in our turnaround times. It was very easy to use, very easy to implement, but it didn't really, we think, help us as much as we hoped. So that's why we kind of give it this score. We did another study on using incidental pulmonary emboli. And so this is when we're not actually looking for the PEs. And in that case, AI was extremely helpful. So we improved our sensitivity and our miss rate. And I think this actually improved our performance. And this was using a triage tool. So not the intended use of the technology. So everyone tries to get through the FDA with the least amount of burden. But we found this tool to be incredibly useful. And this is an example of a PE that was missed, that was caught by AI. And it's really cool. So, with this, we ended up having to set up some new sort of quality improvement workflows within our department. So now, if the report is negative, but the AI is positive, we started doing some QC double reads. So actually adding this technology increased the amount of work that we have to do. But I do think it's very valuable for patient care. And I think it improves the quality of care that we're able to deliver at UAB. So another category of products is kind of this computer-aided detection. So that's saying like, hey, look over here, right? And so as you can see on the image A, there's a really faint, difficult to see nodule on chest X-ray. And the AI is highlighting it with an activation map. And then on a CT correlate, you can see the nodule. This is the other category of products that the FDA recognizes, which is computer-aided diagnosis. And so in this sort of technology or workflow, AI is looking at the nodule and giving a score as to how malignant it thinks the nodule is. And so here you can see that, a pointer. I don't know. But anyway, over here, you can see there's this nodule. It's rounded. It has, maybe there's something going along the bronchus. There are some soft tissue thickening. There's little spiculations and some, ground glass. And so the algorithm or the computer thinks that this is highly suspicious for malignancy. And then this is the computer is now classifying and saying, no, this is 2 out of 10. It's probably much less likely to be malignant. And this has a more lentiform shape. It doesn't look like anything that's too worrisome. And so the risk is kind of goes from like triage saying, hey, read this first, detection saying, hey, look over here, and then diagnosis saying, hey, this is what this is from A to B, and that's kind of what it is. Another big category we're seeing a lot of activity in radiology is this idea of doing deep learning reconstruction. And so, with our MR scanners, a patient, a typical exam could be 25 minutes where we run a bunch of different sequences. We can do abbreviated protocols where we just, run 1 or 2 sequences, get the patient through in 5 minutes. But with deep learning reconstruction, you can theoretically just shorten that image acquisition. And then if you can shorten the image acquisition, you can improve the throughput on the magnet. And so that's kind of the idea with that technology. We actually tried that out here at UAB, and we actually didn't like how the images looked, so we're not using that anymore. But this is just an example because that I still think is important because every single hardware manufacturer is now building this technology into the scanners. So the newer scanners are all going to have this technology as part of their reconstruction. But this is just an example of a prostate MR examination. As you can see, the images look pretty comparable, at least on this screen. Not in our nice dark room, with beautiful monitors, but the image on the right was acquired with a 40-second acquisition, so much shorter image acquisition time. And so, kind of the idea. I'll move through this rather quickly, but the idea is to patients don't really like being in the magnet. They get claustrophobic. It's like if you can get them through, there's some satisfaction there. If you have motion artifact, you can reproduce it and redo it. Like if you can acquire the images faster, that helps reduce that motion artifact. And then if you're improve the throughput, then we can scan more patients. We can ultimately decrease the cost. Our tests can be more effective, et cetera. And so that's kind of the value there. I'll talk a little bit about opportunistic screening and care coordination. So I'll just kind of jump through pretty quickly. But so heart disease is one of the leading causes of mortality. There are a lot, at UAB, we're doing a ton of CT scans, right? And on every single CT scan that we do, we can derive insight into the underlying physiology of a patient. And so with opportunistic screening, the idea is we can detect or quantify actual incidental findings that are detectable on our imaging exams that could add value or change the sort of trajectory of a patient. So the goal is to identify high-risk individuals and get them to the appropriate physicians. So just some of the things that are kind of being done or discussed a lot in the literature are detection of coronary artery calcium, right? So we can, if patients have a high agatin, we do CT scans from some of the cardiologists just to quantify the amount of coronary calcium. We can now do that in an automated way on all of our CT scans if they have a chest non-contrast exam. And so there are some other things that we can essentially look at. And the idea is if we can calculate these things, then we can help improve, get patients on the appropriate medications on a population health sort of level. And so the idea is, patient comes in with abdominal pain. This is like the typical workflow. And now if we add AI into that, we can essentially identify some of these things that may or may not be missed, or may not be, a lot of the times they're not missed, but they're reported inconsistently. And so if an exam is for A, right, then most of the time we answer, our number one priority is in radiology is to say, okay, this was the question you were asking. This is the answer of what it is you were asking. But there's a lot of extra data and a lot of extra information there. And so the idea is we can actually provide the primary care doctor with some information that they might or may not have understood based on, grandma's CT scan from the ER a month ago. And so the other idea is to use, we've actually done this here with one of the surgeons using adrenal nodules, but to make sure that people don't really fall through the cracks is essentially using some natural language processing to identify where there's actionable findings within our reports that may or may not go worked up or followed up. And so I'm just gonna kind of jump through this really quickly and just trying to save some time here because I would like to leave some room for discussion. But one of the ones that we built here at UAB was to detect cardiomegaly. So we created some AI algorithm to automatically calculate the cardiothoracic ratio. And then what we did was we ran the software that we developed on 16,000 patients from UAB. And then we looked at the outcomes in I2B2. And we showed that this metric that we calculated is highly predictive of future MI, heart failure, stroke, and arrhythmia. So just kind of like a research idea of something you could do is train an AI algorithm and process a whole bunch of data retrospectively, and then calculate some really interesting insights. And so I will sort of just jumping through. The other thing we're seeing and that I think about a lot is this idea of the waiting room of the future. So, we kind of, the way it works now is you come in for your MRI, you wait for a long time, you finally get into the magnet, or let's say a CT scan, you finally have your exam. And then afterwards, you just go home, and then you're on your way home, and all of a sudden somebody calls you and says, you have a big PE, like you need to go to the ER right now. And so this happens all the time. So, but what we could do is we could have AI process it. If AI doesn't get it right, that's okay. It's not that big of a risk. If AI gets it right and they have PE, then we keep them there and we review the images, confirm that the results are correct, and then we tell the patient where to go. We call the referring provider and we say, hey, do you need this person? Can this person go home? There's no right heart strain, it's a small one, like you just want to call them in some Eliquis or something like that. and have a call with them? Or do you need to, or no, like maybe this is a bigger one, you're worried they have got, severe comorbidities and they need to go to the ER right now and we need to monitor them. And so it helps in terms of disposition. And so, anyways, that was just like a ton of examples of things that are going on in radiology. I'm going to take off my very myopic view and sort of expand it a little bit and talk more about generative AI in healthcare. And so what is generative AI? It's an AI that can generate new content based on prompts. And the idea is that you give the model a prompt and it will generate some text, images, or a video based on historical data or whatever data has been trained on. And so the benefits of this is it's super efficient, it's creative, it's automated. The weaknesses are we have to worry about hallucinations, bias, and misuse. So this is from a Nature paper. I think this is a pretty good list of like some of the applications in healthcare that we're seeing. One of the big ones that really may or may not affect the people in this room, but impacts people like my wife, who's an OB, is the clinical documentation, right? It is so much work to go and record all these notes, create all these notes, and I think AI would be tremendously helpful in terms of creating those notes. We're starting to see. I was given a talk at another health system yesterday, and what they're using is, which is pretty cool, but they're using Microsoft's Copilot to actually generate the responses to their in-basket, which is a very popular thing that people are starting to do now, because what's happening is, patients have access to this AI. Like we can't stop them, right? Like no, it doesn't matter what the FDA does, right? Grandma gets sick, people are going to ChatGPT and trying to figure out what the diagnosis is. That makes it really, really hard on the primary care doctors, who now have to be like super, super extra specialists in every single thing, because the amount of information and the granularity of data that's getting through about these differentials and what these things are, I mean, they might have never even heard of some of these things. And so it's becoming really, really challenging. And so in order to fight back, to combat it, I think that AI is going to play a big role. So Heersink Institute has set up this a GPT for Heersink. What it does is, you can go and ask it questions and learn a little bit more about the Heersink Institute. If some of the folks in anesthesia have done this, this is pretty cool. But if you go to anesthesiology.ai.uab.edu, you can actually use these generative AI tools, which is just essentially calling the OpenAI API. And there's a couple of different fun tools you can play around with. It's pretty awesome. But they've done a couple of things. One of the ones that we tested and helped them develop is generating your promotion and review packet. And so if you go to this website, if you go to anesthesiology.uab.edu, you can just upload your CV and AI will generate your entire promotion packet. It's really cool. And then we also tested one around generating a recommendation letter. So if you need to write a letter of recommendation for somebody, you can upload it to this website. And this is all behind the UAB firewall. So we have a VA, Microsoft, it's all above board. Can't use any PHI in this tool, so don't try to do that. But you can, it's really cool. So we've actually tested this with people, and we've noticed that everyone consistently has said that, well, not everyone, I'd say like 80% of people have said that it has saved them a pretty significant amount of time of what it would be to write a good letter of recommendation. Now it's never fully done. You're never gonna just like take this letter and say, hey, go, like I'm submitting this, it has to be reviewed and edited. And then one of the things that's a little scary is, sometimes it will make up positions or papers or something. So you have to be really careful. You have to double check for sure. We've definitely seen that. We've seen like people get, we've tested this with over 30 people's CVs now. And sometimes we see, like a position or something that the person never had pops up. So you got to be a little careful. Now, this tool works with the UAB format. CV. So I don't know how well it will work with other UAB formats. It uses like a retrieval augmented generation model and specific instructions to search certain areas of the CV. So if the formats are off, but anyway, it's just a cool use that's relevant. This is an idea of doing transcription, medical documentation, and I think this is really powerful. And I think we're going to see a lot of this, but there's this concept out there around having ambient scribes. And so just having your phone listen to the conversation. This actually happened to me. I went to the doctor, I went to the primary care doctor, didn't even look at me once. Like he just sat in front of the computer like this, and I was like, okay, really happy I'm not a primary care doctor. But I think there's kind of like this paradox now where it's like AI actually helps deliver more patient-centric care, because now instead of looking at the computer and just typing in the answers or the questions to fill out all the annoying documentation required to bill for the services that they're providing, you can be a little bit more focused, have an ambient scribe record all of the conversation, and then use the large language model to generate the documentation. I think that's going to be tremendously powerful and bring a lot of satisfaction back into the practice of medicine. And so, anyway, this is actually a tool that we use in radiology. I like to call it my cheat code or easy button. But if you we just dictate all the findings, and then we have fine-tuned we have a fine-tuned AI large language model based on my personal individual reports and like the style that I use. And then after you click on the conclusion, after you've uploaded all the or implemented or added all the data to the findings, the conclusion is automatically generated, or the impression is automatically generated by AI, and then you just have to go and edit it. And I think this, unclear if it actually saves us time, but it definitely feels, you feel like a little bit of a cognitive load or decrease in cognitive load. So this is just one of the tools that we're using in generative AI here. So it minimizes the amount of words we have to, talk into the microphone. It's simple, it's easy to use, it's fully integrated into our system. There's no going to another website and copying and pasting text into one thing. Just automatically go. You don't even have to click a button. You just, once you're in the field, it will automatically happen. So clinical value, I don't know that this makes us better, but it's super simple, and there's probably an ROI in terms of our efficiency. Okay, so
the radiology reporting system is web-based and then goes into Cerner. How does that interface?
Oh,
I'm trying to figure out how pathology can use this.
Oh yeah, so with this tool, we dictate in a system called PowerScribe 360, and it is a nuanced product. And this tool is kind of hacked actually, but they're reading where that window is on the desktop, and then once the actionable event is clicking on the conclusion, and it transmits the text data to this large language model, and then generates the impression, and then spits the impression back, pastes it into the screen that we're working on. So into that program called PowerScribe. And all these models are fine-tuned for each radiologist. So we have each radiologist has their own custom model that is trained based on the way that their dictation style. So it's all custom. So lessons learned. I'd say one of the things that's really important if you want to get involved in AI. Like we probably couldn't have done any of this stuff if it wasn't for Dr. Cannon. She was just super helpful and super supportive, and just gave us the resources and said go. And so we had a lot of top-down support. That got us some shared tools for research, and some tools to go buy some stuff to put into our clinical workflows. And then we also created a group, AI imaging group. If anybody wants to join that group, you're more than welcome to come to our meetings. We meet once a month, and we just talk about AI. We invite vendors. We would do a little bit of a journal club, and we just kind of talk about things. One thing is, I think it's easier. Explainable AI is really important, and black box stuff is just it's hard to wrap your mind around it. So if you have AI that is producing something that you can like rationalize and then check. So it's like very hard to say, yes, this is cancer, right? But if it's like this region over here is suspicious, or this measurement is too much or too big, that's really, really helpful and powerful. And I think it's more important. I think black box AI really needs very rigorous validation and safeguards. And I think there will be some applications that happen in the future like that, but I don't know what it is. Data is super important. I think one of the things that I found is, I'm not a super technical, I'm not a data scientist, I'm a radiologist. But one thing I have realized is I understand the clinical problems and I understand the data that we have to make decisions, and I understand what or how it could be used. And so the big benefit that I have, or the value that I have, is identifying the problem, collecting and curating the data, and then partnering with people in the computer science department or other data scientists in order to train and build a model. So it's all very collaborative. I work with several different PhD scientists who help do the model training and development, and I do a lot of data annotation curation. And so you don't have to necessarily be a data scientist if you want to do AI. I think having the domain expertise that you have and the sort of where you are, the position that you're in, is very helpful. And if you build it, if you collect the data, if you collect a really, really nice data set, everybody will. So focus on building data sets and partnering with data science. Plan before you deploy. So if you're going to deploy a new tool, just doing a rigorous study, it's just amazing. Everybody is using these tools now, right? Almost nobody is doing prospective studies. It takes one extra step to just say, okay, this is going to be our success criteria. Call it out before you go, and you will have very rigorous publication, and you'll be testing things in the way that you should be, as opposed to being able, playing Monday morning quarterback, actually it really helped us over here, but that wasn't what we bought it for. It will keep you honest. And then I think this is just a really cool and fascinating application that's like a pathology-based application. But so this is a prostate cancer multimodal AI test that just got breakthrough designation from the FDA. But it's really focused on the clinical problem of, if you have a patient with prostate cancer, should you give them short-term androgen deprivation therapy with radiation therapy? And so what they did was they created an AI biomarker, and if the AI biomarker is negative, then it really shows that these patients may not benefit from short-term androgen deprivation therapy, which sounds horrible. I would never want to undergo that treatment. And then the other one, if the biomarker is positive, then you might say, well, these people, we should probably get them to try that because it would be useful in that scenario. So I think you could start to create precision medicine applications. It's almost the same. You think about it as AI could be like a PDL, right? You're gonna measure some sort of biomarker in order to differentiate between starting or not starting a specific therapy. And I think that's where we'll move in the future. Now, the problem with this, just to be a little bit of a devil's advocate, is this is really cool, and I think this is where we're moving. But the big problem is what happens when you start adding new therapies? And how do these models, what happens with these models as care evolves? And so that'll be a problem, right? Because it's maybe we shouldn't even be doing radiation. Maybe we need to be on a theranostic now. All right, so these things are going to evolve. But I do think there's going to be some really exciting research, some good NIH grants to go after, and some. I think this is where we'll end up moving. And then the other thing is multimodal, going multimodal. I would recommend trying to figure out, well, how do we take some of the pathology data, plus some of the radiology data, plus some of the genomic data, plus some of the clinical data, and how do we create risk models to identify who should be on what? I think is going to be a very powerful thing in the future. And so, kind of in summary, I can't believe that this was timed actually well. But in summary, so AI, we're really talking about augmented intelligence. How do we improve the care, the quality of care? How do we improve our job satisfaction? How do we how do we overall improve our performance? I think we're in the peak hype cycle right now for generative AI. I mean, I hope that the excitement and the innovation continues, but I wouldn't be surprised if people are a little disheartened in the next year or two. And then some of our key factors for success, like we like to focus on the clinical value, the simplicity, and what's the return on investment. And then I think really like what pathology could focus on is really honing in on what's that clinical problem, where's that decision point between two treatments or between two different disease states, and then going multimodal. So that's all I have for you. So thank you for inviting me to come talk. I'm happy to answer any questions you might have. Yeah.
A few different questions, but
Sure.
I'll start with one. In terms of the CT and MRI, do the AI models work based off of two-dimensional data or three-dimensional data?
That's a great question. So it could be both. It could be both. So it really depends on what sort of architecture you're developing. So there's like pretty good open source models to do 3D AI. So there's a 3D MNUNet is pretty good. So it could be either. The application that I showed you where the one that we built where you just measure the cardiothoracic ratio, it's actually, it's fairly complicated, but the actual inference is being done on a 2D image. But we have like a bunch of different steps in there where, we're essentially running it on every slice, and then we're trying to figure out where is it the largest, where's the heart the biggest. And then we use that as our key slice. So it could be done on 2D or 3D. It just depends on what you're interested in.
And then just to follow up on that, do you employ any like quality control algorithms to either minimize things like motion artifact or flag things such as like poor contrast timing?
Yes. So we do have some quality control and also series selection kind of modules that we've kind of developed. But a lot of these tools will have that kind of built in. It depends on if it's like a vendor application or not. One of the big issues that we actually ran into was sometimes we actually found that there were we looked at our cases where we had a PE and the algorithm did not report a negative. We actually found out later it's like, well, the right data didn't actually get there. So we had like a tech, we had a tech had to repeat the scan, and only the scan with the crappy bolus got there, and not the one with the good bolus. So all those things are really important to think about in terms of your if you're actually going to deploy it. Now in the research setting, it's like you're kind of figuring stuff out and tinkering, and there's a lot more room for error, because you're not actually depending on how you're using it. Yeah.
I'm curious how you broke down the barriers to work with vendors and industry leaders in this area within the UAB system. Do you have any issues with collaborating with outside like industry?
I mean, yeah. That's a great question. It's painful. It's just super painful.
Speaking from experience,
Yeah.
I'm wondering how you got there.
Yeah. So I mean, we got one of the ways that was helpful was like I have had some sponsored research money, so that helps. But even though I got a joint grant with a company, and it was like a $250,000 subaward, it still took UAB like 18 months to get a contract finished. So I mean, it's persistence, I would say. But yeah, working with vendors is tough. It depends. So when we're buying an application clinically, that's actually much easier than trying to do something research, because we're like, oh, we need this thing, and it goes on the procurement pathway, and it stays away from the campus side, and is in the Health Services Foundation side, and then things will just go through because we're just buying the product. This is what we need to do our job. And so from that perspective, that you gotta kind of break down that wall of like, hey, this is campus, this is hospital, and the Health Services Foundation is super tight about things. In terms of working with industry, I mean, it's fairly complicated, but I could probably talk to you for like how long. I've got some stories. So, yeah.
I have a couple of questions.
Oh, sure.
Oh, I'm sorry.
Oh, yeah, I think, yeah.
Go ahead.
Oh, yeah, go for it.
Yeah,
You can ask you one question.
Yeah. Well, see, we still have 2 minutes, yeah, so.
you mentioned about the power scrap. Is that part of a dragon or a dragon? Is it a power scrap input? Is it a dragon dictation or separate?
Oh, yeah, so it is part of our, so it's actually a separate application, but it uses our, we're dictating in Dragon, and then it goes to a separate system. Nuance has released, we've been using this product for like 2 years, and actually Nuance just copied it and released their own. So they have their own sort of version of this now. We haven't tested theirs because we've already have the other one implemented and we like it, but yeah, so I don't know what they have in the pathology space, but they have some sort of automated.
My second question, you mentioned about a PE, the PE system. Does it have an input from the laboratory data, like a D-dimers or anything?
No, it's only imaging data. So it's just, we basically, we have it set up so we have all of our, we set up a bunch of different AE titles. We route our CT data to this AI software. It generates a result, and then that result is then associated with the study, and it gets pushed out to all the workstations with a little widget on it, and then it creates a little badge in our work list. Yeah.
I'm fascinated that you can upload your impressions, or AI to help you upload impressions to it. Can it go the other way? In other words, as pathologists, we often get a biopsy with minimal to incorrect history.
Mm.
But all that information is in the computer system.
Yes.
Can AI say, give us a quick summary? This is the patient's history, and this is what we're really looking for.
Totally. I think that's like what you need to like knock down the doors of the Informatics Institute and get them to like be like, hey, we need better ways. I mean, in radiology, we see this all the time. Like I get a study and it's like there's no clinical note, and it says the indication for CT other, and I'm like, okay.
Entry admission notes and all that, they're all in there, but we have to click like 20 buttons.
Oh, yeah.
Read it all.
And you can't find it. You can't find it. You're reading through like respiratory therapy notes, trying to figure out like where's the actual right note. No, I think we're very close to that actually being something that will happen in the future. It's not a if, it's a when kind of a scenario. I think the only problem and the thing that we have to be careful of is the hallucinations, right? So, using these technologies, like it could make up things about patients that doesn't exist. And so there has to be really, really good safeguards in place for doing that. One way of doing that is just like using AI to find the right note and then reference the right note so that you don't have to look everywhere, and that like the data has to be in a note somewhere, right? And not generated. So there's ways around it, but it has to be thought of. Like you wouldn't want AI to accidentally make up like a lab value, because you have 100 patients. Every single patient with lymphoma has elevated white blood cell count. So now like it just making up random white blood cell counts. You have to be careful if you have the word lymphoma in the order requisition or something like that. That's like one of the problems that I see. Yeah. Oh.
It's really impressive all that you've done in radiology. Did you guys do this at department level, or did you have to get buy-in and support from the hospital system as well to implement a lot of this stuff? And if it's that, what was your approach to doing that?
Yeah, so we're a little lucky in radiology in that like we have our own IT staff, we have our own dedicated IT group. And we have our own managed computer systems that aren't really managed by HSIS. And so we have a little bit more flexibility to do that because our entire field is all on the computers and using very specialized software that is highly regulated. So it's very different than the EMR or EHR system. And so, to answer your question, this was done mostly at the department level. Purely at the department level, with a lot of support from Dr. Cannon, who gave us funds, to do this, and and assistants. And so, really like from chair down, was amazing. And Dr. Trudakapani, also, he led a lot of the actual implementation, and work. He was the vice chair of informatics before he, became the chair. And so he really implemented and did a lot of this work. I just get to talk to you all about, all the things that we did as a team. It wasn't just me. There were a lot of people who helped out. I think we have 18 staff in our IT group. So there's a lot of folks, a lot of support, and a lot of people who are super excited about this. HSIS did have to do all of the reviews, so like the routing, like you have to send it to HSIS. They do all the vendor security stuff, and that sort of thing.
Yes. Regarding the first project you did, the missing of pulmonary thrombi, what was the gold standard? How did you know you missed it? Or how does the computer was making a right diagnosis?
Yeah, so we didn't train the model. So this is like a commercially available software that we purchased for our department. The way that we reviewed it was, the initial step was, hey, let's look at discrepancies. So that the initial step was saying like, okay, like if AI is positive and the report doesn't say that there's a PE in it, then let's review that case. And we would go and look at the images, and then we would be like, oh shoot, no, we missed one. And then we'd have to call and make an addendum. So we had a whole QC workflow. So when AI was in the background, we would review every single one where there was discrepancies. And we still do that. We still review, we only review discrepancies if it was positive by AI and negative by a radiologist. Then we'll review those cases. And it's not too many. So yeah.
So my question is, what is your vision of AI in your radiology department? Like, you see that as a screening radiologist in the future, or you see that as a problem solver, or like disease-based?
Yeah, that's a great question. I mean, I see it as an invaluable tool, helping improve our performance and decreasing our workflow. So decreasing our workload. I think that we're still not there yet. I think there's like a long ways to go. But I see AI as being like a tremendously valuable tool in the future to help us. And hopefully, there are certain things that, as radiologists, we're not like, we don't love doing. And if we can get AI to do a couple of those things, that would be great. But right now I see it really as a kind of like a backup or a QC tool is where I see a lot of value. In terms of triage, triage is very, very helpful if there are really long wait times. So like there's places in Europe where you get a CT scan and then you get your report 2 weeks later, right? And so AI is super valuable there if you can identify the one, incidental PE is 1%, like 1 to 2% of our CT scans have an incidental pulmonary list on it. So it's essentially taking the high acuity stuff and moving it that way.
So as I understanding, like your deep learning system actually based on disease, like one problem based.
Yeah, I don't. So yeah, that's a good question. Like, is there going to be like some like foundational model that is useful across every single application? I don't really see that. I mean, imaging is so complex, and it's really like, if you think about imaging and what we do, AI is nowhere near the level of complexity in terms of how we approach image interpretation. Like when we see a problem, we see a case, I see a finding. I identify the findings there, then I have to figure out what it is. And when I don't know what it is, I go and I look at the prior and I say, it didn't change, or it changed. And understanding that and I look at different priors across different scans and different modalities. So I might find something on an ultrasound and I'll go back and I'll look at an old CT and say, oh, okay, that's what that is, And so we're definitely not quite there yet. There's a really, really complex play between lots of different data sources. And I think we're definitely like an order of magnitude away from that. We're at the point where we can do sort of neat things with single pieces of input or single pieces of data. And in the future, it'll be using more complex pieces of data. Yep.
Well, some questions and comment related to the title of your talk today.
Oh.
So one of my areas, MSK pathology, and I deal with your MSK folks a lot. So the challenge is, the IR biopsy for a bone lesion is tiny, and they can't get more tissue. It's not like some tissue where they can do an open biopsy. And then you guys give us a lung differential diagnosis, and sometimes the tumor doesn't fit. We don't have a clue what it is, and we do stents which may or may not help us. So, for those lesions in the red correlation is the key. And I'm wondering if the correlation can be done by AI. Say, the AI gave your differential diagnosis, so we can, describe it, the histology and immunophenotype, and the AI can give us a differential diagnosis with the red top.
Yeah, I think that's a fantastic idea. It's really about having the foresight of saying, hey, let's collaborate MSK, radiologists, and pathologists interpreting the studies. Let's make sure that we're collecting our data in a way in which we can potentially train models to improve